Thank you for the introduction. VTE still remains a very important cause and something that's really a big problem in Australia, so it's good to share a different perspective sometimes from other places, and that's what we'll do today. First of all, how big a problem is it in Australia? So still around 7% of hospital deaths are attributable to VTE, so it's a very it's still a big killer of patients, and this comes from data from 2008, but we're still led to believe this is pretty current data, as we haven't done a lot to change approaches on how we reduce DVTs over that time. Trauma, of course, I'll talk a little bit of stuff about VTE, but bringing it back to trauma in particular. So what I'll go through today is a little bit about VTE itself, and then moving on to how we identify risks and how we manage, in general terms, VTE. And then I'll move on to mechanical prophylaxis, which has been the focus for the last 5 years for myself and others at Medtronic in trying to treat, what do we do about it? What can we do to use what's available to us? So first of all, if I start with a diagnosis, we've got a little picture here of a textbook DVT. Now, in reality, they don't look like this. There might not be little blood clots. It could be long, continuous string. It could go the whole length of a patient's leg, and parts of that can fall off and become PE. So generally, we'd say the rule of thumb is for every 3 VTE events, there's 2 DVTs to every PE, 2 to 1. The DVT itself is really important, and that's what we're trying to prevent in a trauma setting. But what we don't think of often is the burden of the disease. So a young trauma patient that has a DVT, they might be okay, they might get a PE, but down the track they're going to develop, at least half of them are going to develop these post-thrombotic syndrome. And the burden of this in the community in Australia is pretty large, so we reckon it's about 10 times the cost treating the post-thrombotic syndromes than it is actual DVTs. We've just got a few pictures here of decreased skin tone and things like that and condition. These should be pretty common with some of the older patients you'll see. The first thing to say about DVTs is that it's a very silent disease, so about 3/4, in fact, of DVTs go completely unnoticed by health professionals. So you may think that in your hospital you don't see DVT very often, but in fact it's 4 times as common as you think. So that's the first thing that's really important. If you are in the 1/4 of patients that do exhibit symptoms, this is the kind of things that we're looking for: tenderness, discoloration. You may be able to palpate the DVT, but probably not. I've got a picture here of a PE, and if I had a ruler on here, it would be about 15 centimetres across. So this is a bilateral PE, which is unfortunately fatal for the patient. And as I was saying before, it's not always, DVTs aren't what we kind of think of in the definitions of being a little blood clot. Sometimes they're very long, continuous, stringy things that can break off, and large portions like this can break off. Now, here are some of the things that these may be familiar. Has anyone nursed or obviously a lot of you will have experienced patients with PEs. These are the sort of things that you're looking for here: chest pain, hemoptysis. But more often than not, there are no symptoms. Sudden death is the first that you'll know that the patient has a PE. So around 70% are actually found out about in post-mortem, unfortunately. Here's where VTE sits as a burden within the Australian community. So it's the number 5 leading cause of death. You see that heart disease and stroke and lung cancer and COPD are very much make up the majority of the things that are killing people, but and all 4 of those top ones as well are related to smoking as well. But VTE, largely preventable, not always, but largely preventable. It comes in at number 5. Now, road traffic accidents, breast cancer, these are things that the public has a really high sense of awareness that we need to do things to prevent these, but VTE is very much a silent thing. Patients know that they might get a blood clot on an aeroplane, a long haul flight, but they're not really aware that it may happen in hospital. Within trauma, if we look at trauma patients within this, how often would a patient get a DVT? Now these are all figures of what would happen if you gave no prophylaxis at all. So you'll see that the highest there would be stroke, hip, and then below that you've got trauma, which is up there with hip fracture. So if I break that down again, and again this is, you do nothing, there's no prophylaxis, what are the odds you get a DVT? But within that 50%, multiple trauma is about 50. The incidence in trauma itself goes between about 5 and 60, 63%, depending on what papers you look at. And hip fracture is the most dangerous. Bleeding risk is a really important thing to talk about here because with trauma patients, the number one priority is keeping them alive. So, you know, if the patient is going to bleed to death, then it's not important what happens with the DVT or the PE, because they won't be around for that to happen. But uncontrolled bleeding is the number one killer in trauma and early in-hospital prevention. And I've made a note here as well just to talk about tranexamic acid. Now, this relates to the bleeding risk. This is a new, more controversial point, and I don't know what you do here in Singapore or wherever you come from, but a very controversial thing at the moment in Australia is this use of tranexamic acid. It is for decreasing blood loss, but at the same time, you may increase the risk of getting a blood clot, so further down the track. So it's, there's different opinions depending on who you talk to on this. Does everyone know Virchow's triad? Virchow wrote this back in around 1850. It's really, really old, but we still use his principles to describe how to treat and how to prevent clots. I'll talk about all three things. So stasis, coagulation changes, and vessel wall damage. First of all, stasis. Here are the patient considerations, things that are putting the patients at risk of getting stasis. So age is a factor. You've got paralysis, shock. These are all trauma-related things. And if we move on to coagulation changes, anything that's going to make your blood more sticky and more likely to clot. Often patients are coming in a trauma scenario and they've had an injury, so they're much more likely to be wanting to, their blood is going to want to clot to stop them from bleeding to death. So they're automatically at risk of having a VTE event. Vessel wall damage, they may already come in with the vessel wall damage from the actual trauma itself, but then on top of that, what we do then is give them more vessel wall damage. So we'll do things like add venous access. So these are going to make the vessels more likely to want to clot and form a DVT. There was a study which looked at patients in a general surgery sort of capacity and what happens to the veins in the lower leg. So if you start it, this is your lower leg vessel here, sitting nicely, and then if we add an anaesthetic, you get relaxation of the smooth muscle, and that will increase the diameter by 22%. And then if you add a bolus of a litre of fluid, that will go up to almost 60% higher than normal. So what's happening in this scenario is that your vessels are stretching, and the endothelial lining is very fragile, and it's not really equipped to deal with this. So we can get slowly little micro tears happening inside the endothelial lining, and that may be part of the reason that surgery's got such a high risk of DVT, because it's causing little micro tears, and that's where the clots are starting to form. Okay, within trauma, these are all risk factors for DVT. So, yes, more than 3 of lower extremity fracture or head injury, a venous injury, a procedure, etc. In the ICU, these are all factors here. The trauma itself, before the patient got to the ICU. Atrial fibrillation is often something that people don't associate. And age. when does a DVT happen? So this is a really interesting paper. It's an old paper, but it shows us exactly at what point a DVT is happening following a procedure. So in this case, general surgery. But interesting to note that almost half of DVTs will happen on an operative day. It's on the day of surgery. That is generally when the DVT will happen. Now, the scary thing about that is when you think about chemical prophylaxis, you know, how long is that taking to become active? How long is that taking before it's having an effect in the body? And generally, we get asked this question with the mechanical prophylaxis a lot because people say, how long do you have to have it on for? And all we can do is really refer you back to this and say, well, the risk really drops off after 4 days. So really, in this 4-day period, it's really important to have some sort of prophylaxis in place. The difficulty in trauma is that usually, well, in some cases, I'll show you in the guidelines, chemical prophylaxis is withheld for up to 5 days. So think about the risk. It's already happened, you know. Okay, so on the guidelines, I'm not going to share with you an individual or specific hospital guideline. All the big hospitals in Australia have their own guidelines, but they're generally formed from the ones I'm going to go through now. So these form the basis, the template. These are the big guidelines that are formed internationally. And there's one local as well, the Australian NHMRC. I'll just run through quickly what they say and what they tell us to do. So the first one's the risk assessment profile. This is just a series of things that we're looking to tick off, and they will have a score. So you get a score based on what's happened to the patient or what risk factors they have, and if you have an RAP score of 5 or more, then your risk is really elevated. So this looks like this. This is a chart which you tick things off. So is the patient obese? 2 points. Is their age between 40 and 60? 2 points. This one on the bottom here, over 75, is 4 points. So very quickly you'll see that the risk in a lot of the patients you'll be seeing in a trauma setting is very high based on this. But it's a pretty blunt measure, so it's just, you know, are you high risk or not? Are you over 5 or not? If we move on to the NH and MRC guidelines, there's a big working party in Australia which formed this, and this is a more comprehensive way to go through, and generally the big public hospitals will use this, or use this to form their own guidelines. So there are 4 steps. Don't worry about reading all this writing. I'll run through with what the 4 steps are. Number 1 is more of a big picture thing. So is the patient being admitted for a large surgical procedure or injury? Do they have leg injuries, prolonged immobilisation, prolonged surgery, prolonged immobilisation? Is it this sort of procedure? This flags that, okay, this is someone we need to look at for VTE, we need to do something. Second of all, and this shouldn't be missed without, as an individual theme, because sometimes patients have high risks even though their procedure isn't necessarily dangerous. So have they had a previous DVT, the individual's risk? Do they have an active cancer? Has they got high age, pregnancy, all these things. So that will flag it again. Okay, this is a high-risk patient. We need to do something about the prophylaxis. Step 3 is contraindications for the chemical. So we need to know, especially in trauma, said before, that maybe you need to withhold that for a few days based on the fact they've just had a traumatic event and they might bleed to death. Another one people miss quite often is NSAIDs. So a lot of the older patients that have hip fractures are on concomitant NSAIDs, anti-inflammatory drugs. Number 4, is there any reason why we can't give the patient mechanical prophylaxis? Now, if you've had a motorbike accident and both of your legs are broken, it might be really difficult to put on some mechanical prophylaxis too, so there may be things that we need to consider in this area. Morbid obesity is an increasing problem in Australia. We just increase the sizes every year and we can't keep up. So it's a real problem. We're up to triple extra large on everything. Okay, so after you've done that 4th step, you go to have a look at what do I need to do based on the kind of patient. So in this case, I've gone down just to the trauma and spinal surgery area. And this is recommending low molecular weight heparin 5 days after admission. Okay, is that pretty similar to what you do generally? Yep. Then we've got start from prophylaxis until hemostasis has been established. So again, that could be a period of a few days. And in addition, use to pharma, use the foot pump on admission. So another one is the ACCP, which is, this looks very wordy, but basically it's just saying for major trauma patients, brain injuries, acute spinal injuries, you can use heparin or mechanical prophylaxis. If they're at high risk of VTE, you use both. Or down here, for trauma patients that have a contraindication, you use either or both. The International Consensus Statement on VTE is a large international body from International Angiology. I've identified their trauma section within that as well. That just states to start heparin as soon as possible, or as soon as the bleeding risk is acceptable, okay, or IPC, where you cannot use heparin. So that covers the guidelines. Does that pretty much fall into similar, to what you guys are doing as well? Is that you may find that the guidelines you use here come from these guidelines as well, or in some way are related to them. So let's run through the mechanical. First of all, I'm going to go, there are three things that we can use basically in mechanical prophylaxis outside of chemical. So the first would be general. So mechanical, we've just got the three that we can use, including mechanical. So mechanical is one, inferior vena cava filters, and then of course pharmacological, which is the major one which is used, but in trauma patients it's not always possible. IVC filters look like this. They're kind of look a little bit like a fish hook, and that goes into the interior of the inferior vena cava. The obvious upside to this is that they'll catch a large clot that's coming into the heart and stop it going into the lungs, but the downsides, of course, are that there's a risk to putting it in. While it's in the body, it's always, you're always risking making a clot around the actual device, and then the whole time it's in, it's that way, and then taking it out, there's another risk in addition. So pretty controversial, this one. I don't know anyone in any of our major centres that do this regularly. Is it pretty much the same here in Asia? But again, it's up to the individual clinician. The staple of mechanical prophylaxis are the stockings. Now, we've been using these in Australia for about 40 years now. There's a large amount of evidence around stockings, but interestingly, if you do a search in trauma, there isn't a lot of evidence. So, there is in orthopaedic, but within trauma itself, it's quite limited. So, maybe an idea for some studies down the line, Dr. Tserng. There's no bleeding risk with a pair of stockings. Okay, that's really important to note. But it would be really hard to put a pair of stockings on a patient that's got 2 broken hips. Yeah, so that's a physical limitation that's really difficult that we have to contend with in trauma. How they work, stasis, obviously increasing blood flow. About 140% of baseline is how they work. If they're correctly fitted. If they're not correctly fitted, they may actually decrease the blood flow velocity if they're really tight, which is important to note. But the other one that if you're looking at Virchow's triad, the only way that we have to address vessel wall damage is with stockings. Contraindications to stockings: severe arteriosclerosis or peripheral vascular disease, massive edema is quite often a problem. Very difficult to fit things around pitting edema, and skin condition needs to be good. IPC has a different mode of action, so vessel wall damage can still occur because it's contractual, so it's coming in and out, and during the contractions you can actually stretch those vessels and still damage them. And you'll see here with the blood velocity, they're more effective than a pair of stockings, as you'd expect. A physical pump is more effective in moving blood than a pair of stockings, and they increase fibrinolytic activity as well. We would recommend don't put them on the IPC, that is, with a patient that has a known or suspected DVT. Reason being, we don't want to theoretically mobilise that clot and turn it into a PE. But very similar, apart from that, very similar contraindications to the stockings. Again, with the skin condition, looking out for deformity of the leg, edema, PVD. Fit, you've all heard of foot pumps as well as calf compressors or leg pumps. Has everyone heard of a foot pump before? So it's one of the two modalities that we have for IPC, a foot pump and a calf pump. It works the same way. I've got a picture of one up here in the top right. That's what looks like little booties that go on the feet. Now they increase the femoral vein velocity by about the same as a whole leg compression. A little bit different how they work with the coagulation changes. It's largely modulated by nitric oxide release. There's different indications for these too. So outside of VTE prophylaxis, they can also be used for circulation enhancement, swelling and pain. So the orthopods really in Australia will generally use foot pumps because they get swelling reduction in the knee and the hip, which is a good secondary effect to the VTE prophylaxis. Different contraindications too. So these, you have to be really careful with CHF, people with a weak right heart, and the same with the pre-existing DVTs, not recommended. And just be careful of like diabetic patients, people with not a lot of sensation in the feet. It's quite a large impact. 130 mils of mercury is quite a large impact on the foot. With all of these sleeves and all that sort of thing, you need to be vigilant from a nursing perspective. So we'd recommend continual care, colour, warmth, movement, sensation, at least once a shift. If it's not being done once a shift, there is a risk that the patient will get pressure injuries, and check their skin integrity as well. I've put in 3 papers to mention quickly because something that we've come up with a little bit in Australia anyway is that trauma surgeons who use calf compression are a little bit nervous about using foot compression because there isn't as much evidence, or they've always used the calf compression, and so they don't want to go outside that. And because there isn't a huge amount of evidence in trauma, I've just pointed out 3 quick papers. So first of all, there's a paper here done back in 2011, which foot pumps is used successfully in trauma patients with enoxaparin, and the DVT rate was very low. Another one done a much longer time ago now, 20 years ago, was just looking at both. So there was a series of hip fractures and lower extremity fractures, and they basically did one of each. So looking at the difference between foot pump and a leg pump, and there was no difference at all. Both about 5% DVT rate if you treat them that way. And thirdly, our own Professor Tony Pohl down from Adelaide Hospital in South Australia did an early protocol using a foot pump until they could use a heparin, which is very much in line now with the guidelines on what we'd recommend. Making sure that there is something in place, getting the blood moving early until that heparin gets a chance to kick in and start protecting. And that worked very well. So just to sum up, really, I think that anything to take away from the approach and what we would recommend in Australian terms, we have these conversations all the time with the surgeons. The more you do to prevent DVTs, the better. If you combine modalities, you need to make sure you look for that dangerous period where the chemical is not working yet and protect the patients in that danger period, and combine as many modalities as you can. Not always possible to do everything, but do as much as you can early on. You'll get a better outcome for the patients. Thanks very much.
Thank you, Peter, for the Australian perspective. Okay, so if I may add to the talk, I think for me, with regards to the use of pharmacological modalities, because for trauma patients, as you mentioned correctly, bleeding is always a problem, right? And we have done studies within our hospital to also show that the incidence of DVT and fatal PE in the Asian population is actually relatively low. I'm not sure about your countries, but in our center, if the patients are on sequential lower limb compressors, be it tie length or full length compressors, the incidence of VTE and DVT is in the region of 0.43% for all comers, right? In our trauma patients, it's about 0.8%, the incidence of DVT. So in my center, I do not practice, number one, routine chemoprophylaxis, right? But we do practice routine sequential cuff compressors for all trauma patients who are admitted with no contraindications. So that has seemed to work. I'm not sure whether what other centers have experienced, but that seems to be working for us. Now, for IVC filters, they are sort of my last resort, because even though now we have retrievable filters, if you look at the numbers, a lot of times, even with retrievable filters, only 30% ever get retrieved. Most of them don't get retrieved, and what will happen is that you get thrombosis downstream from your filter, and it doesn't make sense, right? So you have to look at your, I personally believe you have to look at your own population statistics. Nothing beats getting the patient out of the bed as soon as you can. Nothing beats well hydrating the patient well, and nothing beats getting the patient out of hospital, right? You have to balance the risk of bleeding, because in the trauma patient, you might not be able to see the obvious bleeds. You may be able to see the obvious bleeds, but the small bleeds that you never know, for example, an intraocular bleed, right? If we were to give, my personal view is that if we were to give chemoprophylaxis and the guy bleeds into his eye, it's 100% volume, he's blind their eye forever. It's very difficult to evacuate that clot. And if that risk is 1.5% in patients whom I give enoxaparin for, right, compared to my risk of DVT with sequential cuff compressors at 0.8, it's very difficult for me to convince the patient that, hi, I'm going to give you chemoprophylaxis, there's this risk of 1.5 to 10% of somewhere bleeding somewhere that I don't know about, but if I use these compressors, anyway your risks are 0.8%. So when you balance that out, that's how we work out in the hospital. Anybody has any comments about the use of how you all prevent DVT use?
So in NUH also, we are using the IPC only first charge.
Okay.
The patient is admitted to the ICU, we just use the IPC. Then the IPC is our last, I think the last choice.
Yes, the IPC.
But mostly if the patient is having any cardiac issues and the patients are bleeding from using, there is when we hold the heparin, enoxaparin. So basically all the patients is admitted in ICU. No matter the nature, trauma or anything, so we straightforward we will use the IPC for all the patients.
Oh, sounds like interesting results.
Our protocol as well.
Sounds of interesting protocols from NUH, the National University Hospital in Singapore. And
All ICU.
yeah, ICU by default get pneumatic cuff compressors. How about this from JB?
Jadi cross border. In my hospital, we use no molecular weight heparin liberally, because either in ICU or in my general ward. So most of our patients will get without heparin subcutaneously, almost always post trauma. I mean, either in ICU or in my general ward. So because of the logistic reason, also facilities, we don't have as many as cuff compressors like that of them. So we use the brain quite liberally, and either low molecular weight or normal.
How about the bleeding risk and complications?
That is the issue, because if the patient is having a traumatic brain injury, so we will wait until it is a safe window for us to start. If the patient is in ICU, we will use cuff compressors, because ICU has more facilities. So that's the only place that you can use. The only problem that we have recently is that we have a quite elderly man with traumatic brain injury, at the same time have femur fracture. So we have a dilemma. What type of prophylaxis we can use in that patient? So what's your recommendation?
So access is an issue for you for getting calf compressors, is that what you're saying?
Yes.
Well, you will know what I'll recommend. You spend 6 months with me. I'll recommend foot pumps because you can't. And I'm quite draconian about the way I put calf compressors. If the right leg you can't put, there's always the other leg, right? So if both legs cannot put, you put a fit. Right? If cannot, then you take your left arm and you tuck it. No. So basically you can't do anything, right? So you just wait. But the truth of the matter is, if both limbs can't be put, there's always a foot. Okay, for want of a better technique. I'll be the first to say sorry, but I am a bit skeptical about the foot pump, right? But from what you have presented, I will rethink. Okay, but I think, for want of better technique, I think unfortunately for such patients, an IVC filter will not be your best bet. If you're away, yeah. There's very little we can do. So the other thing I just remembered is that remember that all the papers that Peter quoted, okay, or across the board, all the papers that we read, the Caprini score or DBT as well, are all based on very mixed data, both from Caucasian data, from European data. So I think if you look at the Chinese data, unfortunately, we are not able to tap on that Chinese data. And the Chinese have excellent data. If you're able to read the Mandarin script and actually read their data, they're actually very far more advanced than we accord them. They are not into routine chemoprophylaxis at this moment in time. And their studies are humongous studies, and the latest I read was a paper that compared 15,000 total knee replacement in 5 years. I don't know which center can do that. It's in one single center, 15,000 in 5 years. Okay, and they did a DBT result. They scanned that, and they found that if they ambulate them within 24 hours, both times, maintain proper hydration, and with calf compress, with the tech stockings, the incidence of DBT is less than 2%. Those are very big numbers that I think the Western or the English-speaking world cannot ignore. I think sooner or later we will have to look at those numbers. So be very careful when we look at our own population, because the Asian population, we believe, behaves a bit differently. Okay, so maybe take back to your centers and look at your centers, and maybe we can all collaborate and look at what's our real incidence of DBT and how now do we now prevent it. We're not saying it doesn't happen, right? We know that it happens, but how do we now decrease the incidence of DBT? Okay, and how do we prophylax against it? And Peter has shared with us a wealth of knowledge on how it happens and how we can even mechanically prevent it. Okay, I think